So we'll look at some special considerations for trauma and pregnancy. So with a trauma call involving a pregnant woman, you have two patients, and really that's for any call, the woman and the unborn fetus. Pregnant women, as we said, have an increased risk of falling, and they have an increase in total blood volume, as we mentioned previously, and a 20% increase in their heart rate. So they may experience a significant amount of blood loss before you're going to see signs of shock. And the uterus itself is very vulnerable to penetrating trauma and blood injuries, as it's that, again, center of gravity. So as we said, because of that increase in total blood volume, the patient may be losing blood, and that doesn't have to be from the vagina or related to the pregnancy in any way. It could be that, she had an injury on her arm or leg and was losing blood from that. But regardless, if you will see a compensation for a longer period of time due to that increased blood volume or blood volume reserves longer than you would for a patient who was not pregnant. Motor vehicle crash, severe hemorrhage can occur from injuries to the pregnant uterus. Again, abruptio placenta, a major concern here. So that severe abdominal pain with or without vaginal bleeding should be taken as a serious concern, and the patient should be transported to an appropriate facility rather quickly. Improper positioning of the seatbelt can result in injury to a pregnant woman and the fetus as well. The seatbelt should never be placed directly over the abdomen. It should be placed underneath the abdomen across the hip bones for that lap belt portion. For cardiac arrest for a pregnant patient, the focus is going to be the same as with any other patient. You can still perform CPR and provide the appropriate care. Compressions may need to be applied a little bit higher up on the sternum, just depending on how far along they are and if there's any displacement. You could also have the patient tilted up either to the left, or if this is impeding your CPR, you could have left uterine displacement, which if you look in your textbook is going to talk about having someone dedicated solely to displacing the uterus to the left so that it is not lying on those major blood vessels while someone else is doing compressions. Your focus is going to be on the assessment and the management of the woman. So we want to follow these guidelines when treating our pregnant trauma patient, maintaining an open airway, administering oxygen if necessary, making sure they have adequate ventilation. If they don't, providing BVM ventilation, assessing circulation, stopping any blood loss that may be there, and then transporting the patient on the left side. So like I mentioned previously, even if the patient is on a backboard, you can still tilt that up to the left. Thinking about some cultural value considerations, cultural sensitivity is very important. Women of some cultures may have a value system that can affect the choice of how they care for themselves during pregnancy. Like some people only eat certain foods, they will or will not take medications. Do they want to have a home birth? A lot of different things. And then in everyday life, some culture may, not allow for a male provider to be the one to assess or examine a female patient. And if these are the case here, then we definitely want to try to honor these requests and respect their differences. If you're on a dual male provider unit and you cannot have a female provider there, call for an additional unit, a supervisor, whatever we need to do to get that female provider there to help assist with the delivery. So we want to try to make every accommodation that we can. Looking at teenage pregnancy, the United States has one of the highest teenage pregnancy rates, and pregnant teenagers may not know that they are pregnant, or if they do, they may be in denial and not have told anyone because they're scared. We want to respect the teenager's privacy. It's not necessarily your job to tell the parents that the teenager is pregnant, but we do want to encourage the teenager to tell them. Because remember, and I get asked this question every time I do this lecture, so I'm going to go ahead and address it, that a pregnant teenager is technically an emancipated minor, which means that they can make their own medical decisions while they are pregnant. Now, that only applies to while they are pregnant. Remember that if the baby is born before they turn 18, and then in the state of North Carolina, their parents would go back to making their decisions while they can still make the decisions for their baby. But while they are pregnant, they are considered emancipated. So let me give an example here. If you have a patient who is 16 years old, who is pregnant and wants to be transported to the hospital, but her parents do not want her to be transported, all right, you have to honor her wishes, but you also don't want to be the one to tell her parents that she's pregnant. So in that case, you would really want to encourage her to be the one to tell them. So in that case, they might want her to be transported, but even if they don't, at that point, once they know she is pregnant, there's nothing that they can do because she is technically emancipated and can make her own decisions. But again, try to let her be the one to break that news to them if possible, if it comes down to that. But if it's not imminent and they think, they're okay with her being transported, then they don't really have to know. So that's definitely a fine line that we're walking there. So with the patient assessment, childbirth is seldom an unexpected event, but there are occasions where it does become an emergency. So you might have some people who claim they did not know they were pregnant throughout their entire pregnancy, but usually even if they are delayed in finding out or accepting it, they are at some point realize that it is going to happen and they are prepared for it. But again, sometimes it can become an emergency. So we want to try to take standard precautions with gloves, eye, and face protection at a minimum if delivery has already begun or even if it is complete. If time allows, you can also wear a gown or shoe covers, but that is not the requirements. Remember, gloves, eye, and face protection are what is required, and you might see a test question that asks about that. We want to consider calling for additional resources if you have any trouble with the delivery or if you have any concerns about the baby needing resuscitation, then you might need an additional ambulance, as you will have 2 patients. If everything goes well, you shouldn't need it, and you can just transport the 2 together. But if there are complications, then you might need that second unit. Looking at the mechanism of injury or nature of illness, you might encounter pregnant patients who are not in labor. Their complaint might be totally unrelated to the fact that they are pregnant. So we don't want to develop tunnel vision there, but we do want to stay alert and aware that pregnancy could change things, even if it is another illness or injury unrelated to pregnancy. We want to get our general impression, whether the patient is in active labor or whether you have time to assess and address other potential life threats. We want to perform our rapid exam, look at the airway and breathing. Life-threatening conditions with the woman's airway and breathing are usually not an issue during birth, but you might want to apply oxygen if the patient is in labor, just to increase the oxygen getting down to the fetus. A motor vehicle crash, assault, or medical condition can all cause a life threat. Certainly there are other things that can cause a life threat, so remember it's not always about delivering the baby when it comes down to assessing a pregnant patient. Looking at circulation, of course, if you do deliver, blood loss is to be expected, but significant bleeding is not. So remember, you're going to try to judge the amount of blood loss here, which can be rather difficult sometimes if you're not accustomed to doing that, and you're also considering the surface that the blood is on. Is it on a hardwood or tile floor? Is it soaked into carpet or towels or a mattress? So that can make it difficult to try to estimate the blood loss, but we do want to try to determine, is this normal? Or are we seeing signs in the patient that are indicating that they are going into shock, where we can anticipate an abnormal amount of blood has been lost? Looking at the transport decision, if the delivery is imminent, meaning it is coming, the baby is crowning, we need to deliver now, then we're going to prepare to deliver at the scene. If delivery is not imminent, then we can prepare the patient for transport. Where we transport to is largely going to be related to patient choice. If you work in a system that will allow for that, if you work in a system that will only allow patients to be transported to a specific facility, then that is what it is. But if we have the ability to transport the patient to the facility that they are preparing to deliver at, where they already have all of their medical information and their doctor is familiar with their case, then that's definitely where we want to try to transport. So we want to provide rapid transport for pregnant patients who have significant bleeding and abdominal pain, who are hypertensive or showing signs of preeclampsia, who are having a seizure that we believe might be related to eclampsia, or who have an altered mental status. One other piece of information I want to add here in regards to the preeclampsia and eclampsia is that a pregnant patient can, a not pregnant patient can develop a eclamptic seizure up to 6 weeks postpartum, and that change in the blood pressure doesn't always have to be dramatic. Usually when we think about stroke level blood pressures, we're thinking about 180, 190, 200 systolic. But even a slight change in the blood pressure, like if a pregnant patient or a not pregnant patient who is in the 6-week postpartum range, if their normal blood pressure is 110 systolic and it's now 140 and they're having a seizure, then we can still attribute that to eclampsia. So remember, this can happen. Like if you have a patient who is in the grocery store and they have a newborn baby with them and they're seizing and have no other explained reasons for the seizure, most likely it is related to eclampsia. So just wanted to throw that in there. We didn't mention it before, but that can still be experienced there. Looking at history taking, we want to get a thorough obstetric history. So we want to ask about her expected due date, any complications that she's aware of, if she has been receiving prenatal care or if she's not, and then a complete medical history. We want to try to get a sample history determining the due date, the frequency of contractions, any history of previous pregnancies and deliveries. It's very important that we know what pregnancy this is and also what delivery, because that could change things for us. If this is, her 5th or 6th child that she's giving birth to, things are probably going to progress a lot more quickly. Even if it's the 2nd or 3rd pregnancy, it's going to happen a lot more quickly than the 1st. If there's possibility of multiples like twins or triplets, we need to know that so that we have the appropriate amount of equipment, and if she's taking any drugs or other medications. We also want to ask if her water has broken, and if it did, whether the fluid was green or what color was it in general. If it was clear, that's normal. If it had a little bit of a yellowish tinge, that's normal. But if it's green, brown, or has a foul odor, that's definitely not and could be a indicator for meconium, which is when the baby has had a bowel movement in utero. That could lead to a lot of infection for the mom and the baby. Moving on to the secondary assessment, we're going to assess the major body systems as needed, with the emphasis being on their chief complaint. If the patient is in delivery, we're going to focus on the contractions and the possible delivery. If you suspect that delivery is imminent, then we need to check for crowning. Remember, we don't want to invade anyone's privacy, so we're only trying to look and expose if we have to. So if we suspect that the patient is in labor with imminent delivery, then yes, we do need to check for crowning. Looking at vital signs, we want to try to check the pulse, respiration, skin color, temperature, condition, and blood pressure, and be especially alert for any changes in the heart rate, like extreme tachycardia. Heart rate's going to be a little bit higher, especially if they're in labor, but also looking for hypo and hypertension, which could be emergent. So again, hypertension, even mild, may indicate more serious problems. And then looking at reassessment, we're going to repeat the primary assessment, obtain another set of vital signs. We're going to check for any interventions and treatment. In most cases, childbirth is a natural process that does not require your assistance. So you are going to assist the mom here, but I want you to keep in mind when you get in that situation and you're feeling nervous and you're not sure if you can do this, that women have been having babies for hundreds of thousands of years, and that baby is going to come. Okay, that baby is going to be born whether you do anything or you don't. Now, it could make it easier on the baby, make it easier on the mom in a few cases where you do intervene and assist. But if you choose to do nothing, all right, except for hold her hand, that baby is still going to be born. So I want you to just remember that you're not going to make anything worse in this situation, and you're only going to help. If the childbirth is complicated by trauma, then any interventions that you provide to the patient will benefit the fetus. So things like stopping any bleeding, applying oxygen, keeping the patient warm, things like that. With communication and documentation, we want to provide an update on the status of the woman and the newborn after delivery. When we're making our call in, we do want to let them know that now you have 2 patients here, and what the baby's APGAR score, which we'll get into that, what that means, what the baby's APGAR score is, in addition to an update on the patient. For a pregnant patient with a complaint unrelated to childbirth, make sure that you still let them know over your radio report that the patient is pregnant and how far along they are. This could be a determining factor in whether they want you to transport to the emergency room or to labor and delivery, because even sometimes if the complaint is not related to delivery, they still want to see them in the labor and delivery side so that they can be evaluated by an OB, and so they might not want you to go over into the emergency room. If delivery occurs in the field, you need to complete 2 patient care reports. If the patient, the mom has named the baby, then you can use the baby's formal name on the report, but most often you will go ahead and just put baby boy, whatever mom's last name is how that will be written. Looking at stages of labor, the first stage is going to be dilation of the cervix. Number 2 is going to be delivery of the fetus. And number 3 is going to be delivery of the placenta. So that first stage is going to begin with the onset of contractions and ends when the cervix is fully dilated at 10 centimeters. This is usually the longest stage, and for especially a first-time mom, this is going to last on average for about 16 hours. The frequency and intensity of the contractions are going to increase, so they're going to get closer together and more intense. Labor is generally longer in primigravida than in multigravida. So again, that primigravida means first pregnancy. So gravida means how many times have you are you preparing to give birth here. So again, generally longer than someone who has had multiple pregnancies and deliveries previously. A woman may experience preterm or false labor or Braxton Hicks contractions. So there's not really a large way for us to know this in the field. Whether this is true labor or Braxton Hicks, we're going to talk about some things that can help us determine and tell the patient. But of course, if they have concerns, then they probably have already contacted their OB, who has probably already asked for them to just come in for evaluation. Some women do experience a premature rupture of the amniotic sac, so the water's breaking there. Generally, when the water breaks, that means that the baby is preparing for delivery. Now, in some cases of really premature babies, they can sew the cervix closed, they can put them on complete bed rest. There are things that they can do to buy a little time for the baby to be born to make it safer. But usually, if the water has broken, you are preparing for delivery. So again, this chart right here just giving us a few examples for how we can know, is it true labor or is it Braxton Hicks? And so usually this is related to the contractions. How regular are they? How intense are they? Do they come and go? Are they constant? Are they getting closer and closer together? Also, true labor, generally the pain will start around the back and kind of wrap around the lower abdomen, whereas with Braxton Hicks, these are generally only in the lower abdomen themselves. There's a few more things here. I'll let you take a look at this on your own time. I'm not going to read through the entire chart here, but I just wanted to introduce you guys to a few of the changes that could happen between false labor or Braxton Hicks and true labor. So I'm going to stop this portion of the video here, and we will pick up in the next part.